all over the precordium, V1, 2, 3, 4, and the lateral 5, 6, and 1 in ABL. So he has anterolateral ST elevation. So he has both the LAD and the circumflex. And, you know, Occam's razor, he had the left main lesion, which was appropriately stented. And then does anyone know this particular change that he has here with big T waves and this big ST elevation? We sometimes call this something. Anyone got any idea? Starts with tombstoning, yes. And it's called, and that's yes, because it looks like a tombstone. And as guardians of the medical galaxy, if you guys don't recognize this, then you'll be buying their tombstone. And you know those Italian marble imported ones can be quite expensive these days. Inferior STEMI. Here's a person who came in, a 56-year-old Hispanic male, chest pain radiating to the neck. And, you know, this was about 4 hours ago it started, and you can see he's already queued out and his STs have started to come down. But this is an inferior STEMI, just a little bit later on. Okay, question. A 70-year-old Caucasian male presents with substernal chest pain. He takes lisinopril for hypertension and 50 pack-year history. Here is his ECG. So this is someone coming in with an ACS presentation, and based on his ECG, what do you think he has? So take a look at his ECG. Do you think he has, and it's in your book too, an anterolateral STEMI, AFib, a non-ST segment elevation ACS, or non-cardiac chest pain? Which one do you think he has? And the clickers, I have a 100% feeling going on here. Oh, okay, well, close. So this guy, he had ST depression on his ECG. So you, and I can, hopefully I can show that to you. You can see that ST depression here, V3, V4, V5, V6. He's also got ST depression there in 1, 2, ABL. So he's got ST depression. He does not have ST elevation. So that clears off A. So he doesn't have a STEMI. He doesn't have AFib. He's in normal sinus rhythm. And, you know, non-cardiac chest pain, unlikely. I mean, he has chest pain and ECG changes. You have to assume that he's got coronary disease until proven otherwise. So we can't call him D at this point. Let's now talk about markers for acute coronary syndrome. So what markers do we use? You can see here, you raise your glass to troponin I and T because they are awesome. They are very, very sensitive and very, very, not so very, very specific. But troponin I's in particular are from the heart. Whereas the older markers that we use, the CKMB, I mean, we had them in the brain, the liver, and all of that. So this is a very good test. It is now considered the gold standard in all of the guidelines. As mentioned, it's sensitive, but not specific. And I'm sure you all have seen troponitis in your hospitals. And, you know, we know that even stretching, you know, just stress on the heart, someone in really bad heart failure or someone who is septic, you know, where the heart is pumping a lot, that can even release a little bit of troponin. They can have positive troponins. But the classic raising up and peaking that you see is pretty good for acute coronary syndromes. So it's the rule of fours with troponins. They elevate at 4 hours, they peak at 24 hours to 44 hours, and then they go down by about 14 days. And troponin I, remember, is actually, you know, anatomically, it's part of the ternary complex of troponin, which is the sort of the ambassador between the actin and the myosin. Remember, the troponin T, I, and C are there. So that's what we're physically measuring. Now let's talk about how do we manage acute coronary syndromes. Let's talk about the non-STs first. So with a non-ST elevation ACS, we get them in, get them the aspirin, the P2Y12 ADP platelet receptor inhibitor. Remember, that's going to stop platelets from joining together. We give them oxygen if needed. We beta block them. We hit them with a high intensity statin, and then nitrate as needed particularly if they're having chest pain or a lot of dyspnea. But do remember, nitrates are contraindicated if if they've been using any of the PDE5 inhibitors. So ask your males if they've recently taken those. If they have severe aortic stenosis, hypertrophic cardiomyopathy, a right ventricular infarction, or their blood pressure is under 90 or 30 millimeters below baseline, you should not be giving them the nitrates. And then we want to give everyone an IV anticoagulant, and then telemetry, and as I said before, the hotness level. And I'm not talking about, are they like Jessica, Taylor, or the Hammersmith brothers, or Adam, in terms of hotness. I'm talking about Timmy, America. Age greater than or equal to 65. Markers elevated. ECG ST deviation. Risk factors greater than or equal to 3. Ischemia, 2 or more anginal episodes within the past 24 hours. CAD, that is a known stenosis greater than or equal to 50%, or aspirin use in the prior 7 days. And why is America awesome? Because, we're all chilling out here. But it is also awesome because you need to do this in the boards so you know what to do next. Because we know that the Timmy risk score, what their risk score is when they come in, that will determine what you all do next. So if they have a low score, 0 to 2, which is considered low, generally we will do a ischemia guided strategy. So we may do a risk stratification test like a nuclear stress test or some other test, might do an echo, etc. Because we know that their chances of having badness happening are pretty low. However, if they have an intermediate score or a high risk score, so anyone basically with a TIMI of 3 or more, we know that they have a quite significant risk of something happening bad if we don't kind of take a look and intervene. In other words, something happening, a major cardiovascular event within the next couple of weeks, 20, 40%, those are quite high. So generally we will send them for early cardiac catheterization. In addition, these are also considered high-risk patients. Some places use the GRACE score if the GRACE is over 140. If they're having recurrent refractory angina, with either ECG changes going up or down, or troponins continuing to rise, or they're either hemodynamically or electrical instability, or they have a high-risk stress test, or you do the echo and the EF is under 40, or they're presenting with heart failure, or they've had a recent PCR cabbage within the last 6 months, those generally fall into a high-risk group, and we should go early coronary angiography with those individuals. Also, remember your antiplatelet therapy for these individuals. You should be doing aspirin. You should be doing the P2Y12 receptor inhibitor. And that should be continued. If they're coming in with an ACS, they are on dual antiplatelet therapy for at least 1 year. Now, be aware, because you are using ticagrelor or Brilinta, there is a reasonable percent, 15% of these individuals can get what's called ticagrelor-related dyspnea. So they actually start getting dyspneic, and you do an echo, EF's fine, they don't have diastolic dysfunction. Some even get a BNP, normal. And this is a direct effect of this medication on them. So if you have this situation arising, normally what we do is we will switch them to clopidogrel because it is not associated with this dyspnea. But it is something that you will see, as you can see in about 1 in 6 people. Of course, in addition to the aspirin and the platelet blocker, we are also going to give them anticoagulants, typically unfractionated heparin or enoxaparin. We can use, some places use other agents in special cases. What about someone who is coming in, they're so hot, they're on fire, literally. They're still having the chest pain, they're really bad, and we're like, okay, I'm pushing this person to the cath lab myself right now. We want to get them cathed right now. Well, the clopidogrel or the other ADP receptor agents, most of them, they have to swallow them, they have to be absorbed through the stomach, go to the liver, and then be converted. So it takes time, it takes hours. If you don't have that time, normally what we will do is we will give them a GP2B3A inhibitor, which is given intravenously, and it immediately, instantaneously blocks those platelet receptors so that they're taken out of the equation. And we've got a couple of different options to use for them. And just remember to be checking lab work on these individuals each day because, if you get a significant drop in platelets or you may need to change therapy. If they're going early invasive anticoagulant, of course, I mean, the bottom line is here, guys and girls, we are putting this thing up inside their artery and inside their vessels. This is a foreign body, and things like to stick to it. So when we're doing the catheterization procedure and the stenting, we have to have them super anticoagulated. So we actually often have them on very high doses of these anticoagulants during the actual procedure. How about those cocaine and methamphetamine users? You know, we like to, these are the Friday night or the Saturday night specials in our emergency room. I mean, I'm talking, you know, gurneys in the hallways, IVs being yanked out, you know, restraints because, you know, otherwise they'll punch the nurse, speaking in languages that have not been described by the World Language Society as yet, and spitting at doctors, etc. I mean, some of these people are crazy, okay? Real crazy. And what is going to happen to your heart rate and your blood pressure when you're crazy? Okay, it's going up. So that means they're going to get more ischemia and they're going to kill more muscle cells. So what you want to do if someone is acutely intoxicated, number one, hold on the beta blocker. There is some evidence that unopposed alpha will worsen their afterload. And secondly, relax them, get them relaxed. So, you know, whatever dose of, you know, Ativan or Valium that Aunt Millie takes, multiply that by about 40 and give it to them, because remember, their livers are like, and get them relaxed, okay? The nurses will love you. They will be nice and peaceful in sleep, and the heart rate and blood pressure will go down. In fact, studies have shown on these cocaine people where they've actually compared just aspirin and Ativan and nitrate, compared that to full ACS protocol, that they actually did the same. In fact, one study they did better. And it makes sense, because if they're calm, their heart is not working as much, they're not getting as much ischemia and infarction. Okay, let's question 8. Now, a hint here, guys and girls, do your Timmy risk score. So remember, America, very important. A 41-year-old African-American female presents with chest pain for the last month, but since last night, she's had it at rest. 3 episodes, each lasting about an hour, woke up from sleep, severe 9 out of 10 chest squeezing. So she's got lots of risk factors you can see there, and dad had bypass surgery at 40. She's on aspirin, lisinopril, hydrochlorothiazide, rosuvastatin. Vital signs are okay, and the physical is good. You get a troponin back, 1.1, abnormal, high troponin. The ECG shows 1 millimeter ST depression in V4 through V6. So you start her home meds, and you've got her on, your blood pressure's controlled, heart rate's controlled, but despite that, she says she's having this 6 out of 10 chest pressure at rest, and she's now diaphoretic and nauseous. So hopefully you've done your Timmy risk score. And the question is, what do you want to do now? Do you want to thrombolize her, stress echo, urgent coronary angiography, or regiotenacin nuclear stress testing? And your Timmy score should give you the answer. I got a 100% feeling here. Do you all have a 100% feeling as well? Okay. Yay! Give yourself a round of applause. Second lecture. I think that's a record, isn't it, Rex? Yes? Okay, good. Okay. So, by the way, what was her Timmy risk score? What did you guys get? Yeah, I mean, it was way up there, right? So she needed to go to the cath lab. Very good. Now let's talk about treatment of STEMI. And, you know, I'm going to tell you, you can't take a pill and a Ibiza and be better with STEMI. We got to do, remember, this is complete occlusion, as you can see there. So STEMI, our checklist when they first hit with the STEMI, pretty similar. Except beta blockers are really, really beneficial in STEMI, especially beneficial. I mean, they're in non-STEMI as well, but make sure to get them the beta blocker because they are going to reduce ventricular arrhythmias and improve survival. Also, in those individuals that come in, especially if they come in with heart failure or an EF less than or equal to 0.4, we want to get them on an ACE, ARB, or an aldosterone or an aldosterone antagonist early on. Now, the main key difference is with STEMI is that most cases we're not messing around with scores or doing anything. I mean, they have a complete occlusion. Muscle is dying. We need to reestablish flow ASAP. And this is what I'm talking about here. Here's someone with a right coronary artery presented with right coronary artery STEMI with ST elevation, 2-3 AVF, complete occlusion, and then reopened successfully. This is what we need to do in most of these cases. And we know that this works. Not only does it work, but it's better. In the old days, we used to do a lot of this thrombolysis, but all of the studies pretty much showed stenting is better than thrombolysis if you can get it early. So our goal is to do it within 90 minutes of first medical contact if they come to a PCI hospital, or they give you an extra 30 minutes if they're taken to a hospital that doesn't have PCI and they have to be transported. So 120 minutes. And essentially what we're doing is we're finding that occlusion, we're kind of bumping the clot out or sucking the clot out and then inflating a balloon with a stent and reestablishing very nice flow. You can see here after the stent. Now the older obviously is, older someone is, the more complications and the less effective it is. However, we found that we're getting better and better, and the stents are getting better and better as well. Now radial access is, we are doing more and more through the left radial artery. It's pretty much a direct shot up there, and we're doing more and more stenting through this route. The advantage is you don't have to wait if someone's on Coumadin for their INR to go down as much, so you can do it at an INR 2.2. Advantage number one. And advantage number two, it's very easy to control if they have any hematoma or compared to in the groin. So we like to do it if we can through the radial approach. Now, bare metal stents, we can do bare metal stents in those individuals who we think are kind of high risk, especially for dual antiplatelet therapy. So someone, for example, who is a really high bleeding risk, or you don't think they're going to be able to comply with 1 year of dual antiplatelet therapy. Or they're having a planned procedure. So this would be the classic case that I see with this is someone who has cancer and they're wanting to go for a resection and they are having chest pain, and we stent them, and then with the newer stents, they're getting a little bit better with the drug-eluting stents, but the guidelines have not caught up with that. So right now, just so you know, in terms of the duration, because the boards like to ask about duration of dual antiplatelet therapy for you guys. If someone comes in with an acute coronary syndrome, regardless of what happens, so if they present with chest pain, they come in with an acute coronary syndrome, regardless if they get cath stented or not, that person should be on dual antiplatelet therapy for a year, 365 days, regardless of what happens, okay? If someone comes in with, you're seeing them in clinic and they're having, stable angina, which has gotten worse. So it's not a acute coronary syndrome presentation, but it's just, their angina is progressing. Then you have the bare metal stent 1 month rule, and the drug-eluting stent is still 365 day rule. Now, as I mentioned, the drug-eluting stents are getting better now, and they're more sophisticated. So now, and the new guidelines have not completely come out as class 1, but you will see that in the future. It'll be probably dual antiplatelet for 6 months with the newer drug-eluting stents. But right now, that's what you need to know. And for STEMI, the antiplatelet and anticoagulant is essentially the same as someone who is coming in with a non-STEMI. Now, fibrinolytic therapy. Let's say that you have a person that comes in, and it might be that you're out in the middle of nowhere and you don't have any PCI available, or it could be that you're at a place, but there's a really bad snowstorm, so helicopters or ambulances, they can't be transported to a PCI hospital. So if you have someone where primary PCI is not available in a timely manner, 90 minutes, or 120 minutes if it's non-PCI hospital, or if they present within 12 hours of their symptoms, the recommendation per the guidelines is to give them fibrinolysis. So the fibrinolytics that we have right now are fibrin-specific, tenecteplase, retiplase, alteplase, which are better. They open up the blood flow better. So TIMI 2-3 is better flow, TIMI 0 flow is no flow. And then you've got the non-fibrin-specific, which is the streptokinase. And essentially what we're doing is our goal is to dissolve this clot, but hopefully you can see that the actual plaque is still there. So, it's good to get this dissolved, but we often have to deal with this plaque here later. So firstly, what are the acute absolute contraindications to giving fibrinolysis. So any prior intracranial hemorrhage, known structural cerebrovascular lesion, known malignant intracranial neoplasm, ischemic stroke within 3 months, except, of course, an ischemic stroke that you're seeing under 4.5 hours, because now we are actually treating that with IV RTPA. Okay? Suspected aortic dissection, active bleeding or bleeding diathesis, significant closed head or facial trauma within 3 months, or spinal or intraspinal intracranial surgery within 2 months. If their blood pressure is severely high, because we don't want to give them thrombolytics if their blood pressure is real high, because it increases the chance that they'll have an intracranial hemorrhage. And then for streptokinase, if they've received it within the last 6 months, because they can have this allergic reaction, which is really nasty. Okay, let's see if you have got that information. So a 51-year-old woman is seen in the emergency department for chest pressure and nausea that started 90 minutes ago. She's got cardiovascular risk factors. She's on pravastatin and hydrochlorothiazide. So blood pressure and heart rate is stable. On oxygen is 97% on room air. Her troponin is very positive, and there's her ECG. So take a look at her ECG there. So you start aspirin, clopidogrel, and IV heparin. The nearest PCI hospital is 3 hours away. And she's already had chest pain for 90 minutes. So the question is, what is the most appropriate treatment? Admit to ICU and observe, full dose retiplase, and then transfer to PCI capable hospital, transfer for primary PCI, or half dose retiplase with eptifibatide, and then transfer to PCI capable hospital. So there are your possible choices. Let's see how the Guardians of the Medical Galaxy are doing on this one. Wow, you guys are totally rocking it. Dr. Starlord is proud of all of you. So full dose retiplase, right, and then transfer to PCI capable hospital. So most of you guys got that. They've done the studies for the people that chose the half dose retiplase with eptifibatide and then transfer. They actually had higher morbidity and mortality with doing the combination. They were bleeding, they had all sorts of problems. That's been abandoned now. You either fibrinolyze them, then send them to a PCI hospital, because remember, if the clot comes back or the plaque gets more unstable, we need to act. Most of them are going to get cathed anyway when they get to the PCI hospital in a few days. And no one picked the other ones. But just remember, those kind of funky combo things we are no longer doing, and they're not indicated. Good job. Let's now talk about STEMI and cabbage and antiplatelet treatment, because this comes up a little bit. So let's say someone comes in with a STEMI, and you do the usual things. In the old days, some people used to say, oh, don't give them any antiplatelets, because most likely they're going to go for cabbage. No, we don't do that generally anymore. We do the usual stuff, and honestly, the way it happens in the real world is if you can hold those agents, and that would be more kind of, I think, in more of a sort of a semi-elective situation, we hold them if you can, because we know that those increase, the bleeding during the surgery. But in the real world, honestly, what happens is if they need to go to cabbage urgently, they go. It just means that our anesthesia buddies have to give them a little bit more platelets and products or blood during the actual procedure. Now, what about beta blockers? I told you before, beta blockers are really, really beneficial, especially in STEMI, but also in the non-ST-ACS. However, if you have someone who presents in heart failure, or they've got low output state, or they're at very high risk for cardiogenic shock, that tends to be more the elderly people, those with lower blood pressures, those with a prolonged first-degree heart block, first degree, or a second or a third degree, but they don't have any pacemaker in place, or they have active airways disease, asthma, or really, wheezy COPD, then you may want to consider diltiazem if you want to slow the heart rate down. Now, one of the things that happens with STEMI in particular is that the mineralocorticoid receptors are activated. And, you might say, well, so what? Well, the so what is when they get activated, some of the stuff that they do is not good at all. Vasoconstriction of the blood vessels. You can see here Muscle hypertrophy and fibrosis in the heart, not good. I mean, that's stuff we don't want. We want the heart to have good blood flow and repair. So oftentimes with STEMIs, we will want to block this whole system, and we do that with these renin-angiotensin-aldosterone system inhibitors. The ACE inhibitors in particular are beneficial, started within the first 24 hours. Someone with an anterior STEMI who presents with anterior STEMI or heart failure, or you do an echo and they have an EF less than 0.4. Get them on the ACE or an ARB if they can't tolerate the ACE. And then your aldosterone antagonist, so if they're already on ACE and beta blocker and they had an EF less than or equal to 0.4 with heart failure or diabetes, that is a particularly high-risk group. We generally will also add on an eplerenone is the one that was studied the best in the EPHESIS study. Be aware, however, that they don't have any contraindications. So just make sure you check the creatinine and potassium and make sure they're not taking another medicines that will interact with that aldosterone antagonist. Okay, right ventricular infarction. Right on share. So think of a right ventricular STEMI if you've got share, clear lung fields, hypotension, and elevated JVP or Kussmaul sign. Think of RV infarction. And RV infarctions, 50% of them will have an inferior STEMI as well. So you've got to be aware of that. And to check that out, what we ask for, if you see someone with an inferior infarction, we ask for right-sided leads. And we're looking for ST elevation of 1 millimeter or more in V4R, lead V4R. Why is it important to know if they have right ventricular infarction? Why don't we just treat them the same? The reason is, if the right ventricle is not pumping blood properly to the left heart, all sorts of badness can happen. And they can even crash and burn if you give them certain medicines, including things that we often routinely give these people, like nitrates, like morphine. They will crash and burn. So if they have a right ventricular infarction, no morphine, no nitrate, and oftentimes start them on wide open normal saline, because they're going to need as much kind of passive pushing of fluid from the right side of the heart to get to the left side of the heart. And if they are still hypertense, then consider adding dobutamine as well. Question 10. Regarding acute STEMI treatment, which of the following is true? Often includes early reperfusion with primary percutaneous coronary intervention, includes a parenteral IV anticoagulant, such as unfractionated heparin or enoxaparin, P2Y12 receptor inhibitors, including the thienopyridines like clopidogrel, prasugrel, or the non-thienopyridines, ticagrelor, are mandatory, may include early reperfusion with fibrinolytic therapy, if not contraindicated, and if PCI is not immediately available, or all of the above are true. So I have another 100% feeling going on with the Guardians of the Medical Galaxy. Let's see if my crystal ball is working today. Wow, awesome. Okay, so 99% I will take that. So yes, all of the above are true. Now, the person that choose D, yes, absolutely, we will do fibrinolytic therapy if PCI is not immediately available, particularly if we can't get it within 120 minutes. But these other things are also true. PCI is often the way to go. IV anticoagulant, yes, is required. And the P2Y12 receptor inhibitors, yes, are mandatory. Okay, let's talk about complications of acute coronary syndromes. Here is a classical mechanical complication, a rupture of the interventricular septum. And Pitbull and Christina would not be happy if this happened to them while they're on stage. So mechanical complications, let's talk about those. Typically, so the person comes in with their acute coronary syndrome, and they're treated and all of that, and they have a big one often, and then 2 days later, or 2, 3, 4 days later, it's always just at the point where they're being transferred out of the CCU, and you know the deal. Family's there, and you're saying, and how is he doing today, doctor? Oh, wonderful! He's doing so well today. We're going to transfer him out to the floor. And they're like, oh, and then later in the day, it's like code blue, 2A. And it's your patient, of course, and they're in extremis, they're coding because they're having one of these events. So moral of the story, they are stable right now, and we are cautiously following them, okay? the moment you promise them something, the karma might happen. Anyway, So the main ones that we will see, the mechanical complications that we see, are left ventricular free wall rupture, a papillary muscle rupture, in particular with the right coronary artery, because we know a right coronary artery STEMI, one blood flow from the right coronary artery, one supply supplies that posterior medial papillary muscle. And when that's taken out, that can get ischemic, die, and it can pull off. So in particular, think of that if someone's come in with an inferior STEMI. Rupture of the interventricular septum, and then finally, just severe cardiogenic shock, like our patient who in lecture 1 who presented with a cardiogenic shock. So what do you want to do? I mean, obviously what's going to happen is, it's going to be a code situation. So in one hand, or get your tech, grab the echo and find out what's going on, because, the echo oftentimes will tell you what the cause is. And then in the other hand, speed dial the cath lab or CT surgery, because, oftentimes these people are going to need to go urgently to surgery, especially the left ventricular free wall rupture and the mitral regurg with the papillary muscle rupture and the rupture of the interventricular septum. They need to be fixed, in the OR. If you can get someone who's going down the cardiogenic shock pathway, if you can get them in the cath lab really early on, get that fixed, they often will do better. But you can see, particularly with the left ventricular free wall rupture and the cardiogenic shock, the mortality is very, very high with them. Also, we can see electrical complications of myocardial infarctions. This is one of the ones that we fear the most, but we do see ventricular fibrillation. You can see on that ECG. You want to, get them. They're going to be coding, cardiovert them, and if they have unstable ventricular tachycardia, you want to cardiovert them. And most of the time, you are going to get them to the cath lab. Most of the time, this means that something's happened. They've got ischemia back, and the ischemia is causing the ventricular tachycardia or the ventricular fibrillation. If they're more stable, their blood pressure and everything is stable, you can try treating it with IV amiodarone, et cetera, and doing further workup. What about the implantable cardioverter defibrillators? So with these, I think, the main thing for you guys to know, if you've got someone with heart failure, regardless of whatever the etiology is, if they have heart failure, NYHA 2 to 3 with an ejection fraction less than or equal to 35, you should at some point refer them for evaluation for a possible ICD. What about the person, who's come in with an acute coronary syndrome? Let's say you had a big STEMI person and, they went to the cath lab, they got stented, all fixed, no more chest pain, but yet they're still having VT and VFib for, a couple of days later. And you've checked all the reversible causes. They don't have, electrolyte abnormalities. They don't have anemia. They're well perfused. Then what mostly probably happened was that their event caused a damage in such a way that it set up a focus of VT in the muscle of the heart. And those individuals actually need to get an ICD before they go home. If they can't get an ICD for some reason, then we do have another option, and that is the life vest. Especially the guidelines mention, especially if they have an infection, developed, like maybe they got a urinary infection or some other infection that you're treating that you don't want to put an ICD in now because it'll get infected, then think about the life vest. So the ICDs in general, while we're on ICDs, we can use them either for primary prevention. So that means they've never had a cardiac arrest and they haven't collapsed yet. And as I mentioned to you before, regardless of the etiology, ischemic or non-ischemic, if the EF is less than or equal to 35% with NYHA 2 to 3, those generally should be referred to EP. And sometimes they'll do some further evaluation, especially if it's one of those cases where it's, maybe non-sustained or sustained VT. Now for secondary prevention, in other words, that's someone who actually has had a cardiac arrest or symptomatic VT or syncope from VT. So in those cases, honestly, most of them are going to get a device. But if there's a specific and clear reversible cause at the moment that they had the VT, like their potassium was 2 and they had VT and now it's fixed, then you can consider not doing it. But all other cases, most of the time they're going to end up with a device. And we do have 2 zones and 2 therapies for ICDs. The first zone is what most people prefer. it's what's called ATP, or anti-tachycardic pacing. And what happens there is if the person's in VT, the device looks at the rate. So, for example, a typical rate might be 180. And the device actually starts pacing at a faster rate, like say 185 or 190. And the pacemaker pacing kind of catches on with the rest of the heart, and the VT just dies out. And it's pretty successful in a lot of people. However, if that doesn't work after a couple of times, or the person is in VFib, it will then deliver a shock. And the typical joules are 35 internally. Okay, now let's talk about stable ischemic heart disease. And they're not perfect. This is perfect. They're not perfect, but we can try to make them a little bit more perfect, especially with their symptoms. And we do that by treating them with various medications, nitrates, beta blockers, dihydropyridine calcium channel blockers. Remember, they block the L-type calcium channel of smooth muscle, but they are associated with peripheral edema as well. So you're talking nifed, amlodipine, and felodipine here. And all of these agents work essentially by decreasing the work the heart has to do, by either slowing it down and or reducing the blood pressure it has to pump against. And they're pretty effective. Now, ranolazine, or Ranexa, is the new kid on the block. So this is indicated now, per the guidelines, if you have persistent angina on maximal medical therapy or a beta blocker substitute. So that if for some reason the person cannot take beta blocker, the common ones I see are, asthma or bad COPD, then Ranexa or ranolazine is indicated. And the amazing thing about this is it doesn't affect the heart rate. It doesn't affect the blood pressure. It actually has a direct effect on the energy system inside the cell, like at the mitochondrial level, and it actually relaxes the heart muscle and reduces stiffness without those effects on heart rate and blood pressure. So it's pretty cool. Just be aware, especially if they're on DILT or verapamil, that to reduce the dose of the Ranexa, because these are what are considered moderate CYP3A inhibitors, and they do interact. And so here are the ones you need to know, and my little mnemonic here is the strong NP kicks Randy. So strong CYP3A inhibitors, these are the ones where you do not want to use Ranexa. So nifazodone, if they're on any of the protease inhibitors, so pretty much your patients with HIV, if they're on active heart therapy, you don't want to use it. Ketoconazole, itraconazole, clarithromycin, those medicines are contraindicated with ranolazine. So just check that list before you start someone on ranolazine. Of course, the diet, we do the usual things. Diet, we want to cut down the fat and the cholesterol. 10 is the new 5 for fruits and vegetables, guys and girls. So you should be eating 10 fruits or vegetables a day. Mediterranean diet, by the way, has been ranked as the top diet for cardiovascular disease patients, so think about that. Statin, everyone, and blood pressure. We want to get the blood pressure really, really well controlled. And in most cases, you want to get it, that is under 130/80. Exercise, we know that's important. It builds collaterals. It improves production of nitric oxide, improves symptoms, improves psychological symptoms, well-being, etc. And just watch the waste. Smoking, of course, this is a no-brainer, but you want to check on people. Ask, advise, assist, arrange, avoid, etc. And this also now, a new thing just came out just recently, vaping as well is also considered. So don't get your persons off the cigarettes and say, oh yeah, the vaping's okay. Actually, no, it's now considered a cardiovascular risk as well. Antiplatelets, aspirin, most of them should be on aspirin, those with stable ischemic heart disease. If they can't take aspirin, then go with clopidogrel. Beta blockers, we want them on beta blockers. If someone had a sort of a small non-STEMI, and maybe it was one of those ones, they were anemic, or, there was another kind of reason, and it was type 2, what we call a type 2 infarction, that is, and they have good EF, you can actually, after 3 years on the beta blockers, you can actually stop the beta blockers. And, a lot of people find that beta blockers just really slow them down, and the men do not like them as well because they definitely causes erectile dysfunction. If, in contrast, if they do have LV systolic dysfunction, that is EF less than 40%, those all should be on your guideline-directed beta blockers, which is carvedilol, which is probably the best because it has both alpha and beta effect. Metoprolol succinate, remember the S for the sustained release. A common brand name is Toprol XL for this. You want the sustained, okay? Just remember that. I see a lot of patients in my heart failure clinic that are on the tartrate, and that's not evidence-based for heart failure reduced EF. And then finally, bisoprolol, that's the other medicine that is indicated. ACE inhibitor, of course, as we talked about before, especially if they have low ejection fraction, diabetes, hypertension, or chronic kidney disease. If you've got someone who, despite your best medical therapy, is still having symptoms that are limiting their ability to do ADLs, and you've got them maxed out, then that's the time when you want to send them to the cath lab. And if they happen to be on a NOAC, typically just hold those 1 day before the cath. Influenza and pneumonia are very important for them as well. There's another thing that we have called microvascular angina. It goes by various names, cardiac syndrome X, all these things. So this is what, when we have a person comes in, they have a good story, we do a stress test, the stress test may even be abnormal, and then we do the cath, and the cath comes back normal. The epicardial, the LAD, left circumflex, right coronary, all normal. And it's like, what? What is it? And you may have been treating them, and they may have been responding, for example, to Imdur, and other anti-anginal therapy. This is a very common syndrome, particularly in women, and it's likely the small perforating vessels, so the branches off the epicardials that are going in, like the septal perforators and those, have some sort of endothelial dysfunction, and they're not working well. And we like to, interestingly, the same treatment will work for those individuals. Okay, let's have a question. Your coronary artery disease patient has persistent exertional angina despite being on a good medical regimen, which includes maximal doses of isosorbate mononitrate, metoprolol succinate, lisinopril aspirin, and atorvastatin. So you're on a good medical regimen. Providing there are no contraindications, what medicine could you add to the current medication to improve their angina? So there are your choices there: amio, candesartan, vitamin E, niacin, or ranolazine. What medicine, and I'm having that 100% feeling again, might you add that will help their angina? They're already on everything that we normally do. Excellent. Okay, we got 99%. I'll take that. So vitamin E, just so you know, actually has been one of the ones that the meta-analyses and the group out of Oxford and others have shown that are no longer beneficial. Just like most omega-3s that you get over the counter. I have a lot of people that are taking vitamin E and fish oils. Most of them do not work. They're not evidence-based, so you can save them some money. PCI, let's talk about percutaneous coronary intervention. So if they're still having symptoms despite the maximal medical therapy, or you do a stress test and they have high-risk findings, that's when you should send them for PCI. Importantly, it'll improve their symptoms, but does not improve their survival. And they will most likely have to come back for another PCI, more so than if they'd had CABG. I've already talked to you before about how long to delay surgery if they've got a stent. So if it was for kind of chronic stable angina, 30 days for bare metal, 6 months to a year for drug-eluting, and if they came in with an ACS, 1 year dual antiplatelet for both. And if you are going for surgery, we generally like to hold the clopidogrel or whichever prasugrel or whatever they're on 5 days prior and continue the aspirin. CABG surgery. Well, CABG is good, and importantly, it will improve symptoms and survival for a certain subgroup of patients. And who are those patients? Left main disease greater than or equal to 50% stenosis, or 2-vessel disease with proximal LAD being involved, and diabetes or low EF. They actually get survival benefit. So you should make sure to send those individuals to your surgeons. But on the flip side, if they don't fall into that category and they have single or 2-vessel disease these days in 2019, you can actually treat them either medically or send them for a stent or surgery. So we have a lot more options, and we're doing more and better medical therapy these days. Okay, let's talk about hyperlipidemia. Now I put this up a little bit tongue-in-cheek. This is a burger joint in Austin. And this particular burger, I think it's called the Heart Attack. Its buns are Krispy Kreme donuts. It uses 50% fat Wagyu beef, only egg yolk as the egg, and it has 2 slices of lettuce on it. And this is the heart attack. And actually, I do put that up a little bit of tongue in cheek because we know that actually 70% of your risk and your is genetic for cholesterol. Very little is affected by diet. I mean, you can do a little bit, but not much by diet. Also, I want to remind you that the guidelines do talk, and this is a radical change for these guidelines, do talk about 2 groups of people that have not been shown to get benefit from statins. That is non-ischemic cardiomyopathy and people who are on hemodialysis. So for those individuals in general, I would not use statins for them. But these individuals are these are the final 4 groups that are indicated for statins. So if group number 1, and I've got this little mnemonic to try to help you remember, in Cal, the high doctor was modern. So high, it's all about intensity of statin these days. So who should receive high intensity? That's basically the max dose statin. The individuals that should receive the high intensity are the Cal group. So C for cholesterol treatment, A for atherosclerotic disease. So anyone who has any atherosclerosis anywhere in the body should receive high intensity statin. We're talking a Torva 80, 40 to 80, Reserva 20 here. Or the L is if they have an LDL cholesterol greater than or equal to 190. Typically that means they have a familial hyperlipidemia. And as I said before, most of their lipids is genetics. Those are the highest risk. Primary prevention has been shown to be beneficial for those group with the LDL greater than or equal to 190. So those should receive high intensity. Now, what about the doctor was modern? So those who have diabetic, who are 40 to 75 years of old, or those who have a risk of 7.5 to 20% atherosclerotic risk at 10 years, they should receive the moderate intensity statin. And those are typical doses like Simva 20 to 40, Atorva 10, Reserva 10, Prava 40. So that's basically it. With the new cholesterol guidelines, in the old days, it used to be all about, let's check what their LDL is, we've got to get it down and all of that. It's not about that anymore. It's about intensity. And in fact, if you read the guidelines all the way through, which I've done several times, they mention several places that, in fact, regardless of the indication, your goal should be to get those persons to the highest intensity statin possible. In both primary and secondary prevention, that has shown to reduce the events and reduce plaque buildup and improve endothelial function. So it's about the intensity of the statin. Now, if you have someone who is a diabetic, 40 to 70, and let's say they have a high risk as well, let's say their ASCVD risk is 20, then actually they move up to the high intensity statin group as well. Okay, so let's do a question. 49-year-old Caucasian female comes in because she has heard there are some new cholesterol guidelines. I mean, she's got it together. She's got all of the things together. She works for Vogue magazine. She struts in her Louboutins. She's got her Prada skirt and her Guess blouse on and her Hermes bag. And she holds up her phone and it's like, doctor, new guidelines. So she's got type 2 diabetes and has taking metformin. Blood pressure's okay. Total cholesterol 179, HDL 55. Her 10-year ASCVD risk is 1.9%. So the question is, what should you recommend for her based on the new guidelines? Fibrate, ezetimibe, niacin, or moderate intensity statin? Let's see how the 100%ers are doing. All right. So, yes, most of you got it. So she falls into diabetic at the right age group. So she is indicated for moderate intensity statin. Niacin, unfortunately, hate to break it to you guys, but niacin does not work. Does not work in most individuals. So the guidelines actually specifically stated, forget about most of these other drugs. Also fibrates, they said, forget those. They are worthless in most individuals and have lots of side effects too. Ezetimibe, no, ezetimibe is not considered a first-line therapy. It is considered a potential second-line therapy if someone is statin intolerant. So moderate intensity statin is the way to go here because of her diabetes. So in this lecture, we're going to be talking about peripheral arterial disease as well as some other embolic disease and the valvular diseases. So peripheral arterial disease, The mantra here, guys and girls, is PAD, die from CAD. Repeat and augment. PAD, die from CAD. Okay, you guys need to get your coffees going or something. It's more common in men, and as I said, when you see PAD, you should think CAD in these individuals. So we do the screening for PAD with the ankle brachial index. We have them lay down, and we take a ratio of the highest systolic blood pressure in the ankle, and we divide it by the higher blood pressure in the brachial artery. So again, remember you've got this big tube coming out of the heart called the aorta, and it's going big flow down to the arteries in the legs. Normally when you're laying down, the pressure in the arteries and legs should be the same, if not larger, than the brachial. And the reason that is because remember the arteries that go to the arms come off early from the aortic arch. They're a lot smaller, and so the pressure is attenuated. So normally, the ankle over the brachial should be 1 to 1.4. As you get more peripheral arterial disease, there is more attenuation of flow and more resistance to flow, and so the pressure drops in the lower extremity. So now your ankle, and you may get to a situation where your ankle pressure, that is the ankle over brachial index, is actually less than 1. If it goes under 0.9, we call that significant, and that is a failure, and they have screened positive for possible peripheral arterial disease. So who should you do it on? Well, definitely if someone comes in and gives you a history of claudication, do it. But the kind of the bad news is only 1 in 5, 20% of people who actually will have claudication with PAD. So most people with PAD are walking around, they don't even know they have it. So we target those high-risk groups. So people that have lower extremity pulses that are diminished, those who have non-healing wounds, gangrene, other things, or lots of cardiovascular risk factors, or atherosclerosis elsewhere. They might have had a stent. You should definitely consider doing a peripheral arterial disease screening. Now, the big differential diagnosis for these individuals is a condition called lumbar spinal stenosis. And so they'll come in and they'll do they'll do a Rodin. They'll lean over, or these are the ones that, in hospital beds, they're always leaning forward like that, because that gives them instant relief of when they flex their spine, it opens up and the nerves are not being pinched. Whereas when they extend their spine by walking or going down a hill, they actually get worse symptoms. Importantly, they often give you a story. They'll tell you, doctor, it's very interesting. Whenever I go shopping, at H-E-B, Kroger, or Walmart, I don't mind at all. I don't get my symptoms because they are bending over the shopping cart. So anyone who tells you that they actually like going shopping at H-E-B, Kroger, Walmart, etc., light bulb should go off. Something's going on here. Okay? While we like it to be like the textbook, it should be bilateral, oftentimes they will tell you it's worse on one side. You can check deep tendon reflexes, etc. And we want to make sure we diagnose this, and the diagnostic test which will give you the answer is the MRI of the lumbar spine. And I particularly liked this La Pensure, the Thinker by Rodin. Supposedly this was Dante, outside the gates of hell, considering, to enter or not to enter? But more importantly, I love this because Auguste Rodin also gave us this quote: walking is man's best medicine. So this is fantastic. You all should, who's doing activity trackers? Who's on that? Good to see. I've only got 8,500 right now. I need to get up to my 15, but it is important to get your steps in, get active, so you don't have to deal with a lot of this stuff as you get older. Now, what if they have PAD? You do the ABI, it's like 0.7 or something like that. Then oftentimes, if you treat it medically, but if you're thinking of doing some sort of revascularization, we have to image them. And we've got different options for imaging. Here is an example of a MRI showing a nice obstruction here in the common iliac artery, which was successfully stented. So we want to treat these individuals. Remember, PAD die from CAD, so make sure you get them on aspirin or clopidogrel, just like our chronic ischemic heart disease. Statin them, get the blood pressure under control, check their feet. And if they have an infection, if there's any early sign of infection, you know, maybe they've got something on the cuticle, or maybe it's like a little bit of cellulitis, do not watchful waiting for these individuals. You want to get them on antibiotics ASAP, because if this deteriorates, they can really, really run into problems. And smoking is the big one. And you want to do everything you can to stop them smoking. You may have to make a deal with the devil. Like, for example, you may have to tell them, if you stop smoking, I will let you bring in your cute little Shih Tzu to clinic every time, and I will give him a mani and pedi and bring in doggy treats for him. So whatever it takes, get him into a program, get him on the varenicline or whatever. And again, as I talked to you before, avoid secondhand and the vaping as well. So in terms of the treatment, one new change on the updated guidelines is they now, as first-line therapy for someone with PAD, supervised exercise, 30 to 45 minutes, 3 or more days per week for 3 months. That is a first-line indication, which means also that will be paid for by insurance and Medicare and Medicaid. So for your PAD patients, think about that, getting them into your cardiac rehab program, getting them doing that, and then getting them on, that will start them off on a strong foundation and continue their exercise when they go home from that. Silostazol is a phosphodiesterase inhibitor. This works really well. It improves their walking distance and reduces their symptoms. But importantly, they've got to have normal LV function. So the mantra here, guys and girls, silostazol, phosphodiesterase inhibitor, normal LV function. Repeat and augment. Silostazol, phosphodiesterase inhibitor, normal LV function. Okay, I wanted you to repeat that because it's really important, because if you give silostazol to someone who has heart failure of any severity, you will kill them. And the boards don't like you doing that. There are also some other options for individuals, but these are not considered class 1 right now. So if they have, just like with coronary disease, if someone is on maximum medical therapy and they're having still symptoms that are interfering with their activities of daily living, that's when we need to think about revascularizing them. It will improve their symptoms. We can do a stent, particularly for proximal or short segment lesions. Here is a right superficial femoral artery that has severe PAD and then was successfully stented here. Or surgery and bypass. So this is for longer lesions and for occlusions. And I'm sure you're familiar with the classic one here is the FemPop bypass that is often done. Okay, question 13. A 73-year-old woman with a 5-month history of calf pain, left greater than right, that comes on when walking or standing, worse when walking downhill. She does not get the pain when she is pushing a cart buying groceries. She gets relief by sitting down and leaning forward. Which study will likely reveal the cause of her symptoms? An ultrasound, an aortogram, an ABI, an MRI of the lumbar spine, or CT abdomen? And here are the results. Yes, most of you guys are on the money. So this is classic lumbar spinal stenosis, which is the lookalike for peripheral arterial disease. And the best way to diagnose this, the gold standard, is the MRI of the lumbar spine. We would not do the ABI because this story is not consistent with PAD. It is consistent with the lumbar spinal stenosis. And so the ABI is not going to be helpful in this case, as are the other things. Now, acute limb ischemia. This is kind of like the STEMI of the limbs. This is complete occlusion, pain, reduction of pulses, sensory loss, muscle weakness. And this, just like a STEMI, is a medical emergency. You got to get them on IV heparin immediately, and then you have to immediately send them to the cath lab. But this time it's for invasive angiography of their arteries of the leg or their arm. And then fix it, because this is an emergency. Every time is muscle, time is myocardium, but time is also muscle here. Importantly, if they've come in early, typically that is if they've come in within 3 hours, and most people do, unless they're completely wasted and have fallen asleep outside or something like that. They may not. But typically, this will wake someone from their sleep. It's severe pain, etc. They'll come in. So most cases, that's the good news, and we can get them in, do the urgent, immediate invasive angiography, and then fix it, either with catheter-directed thrombolysis and or embolectomy or surgical revascularization. Unfortunately, about 1 in 5 person waits too long, and by the time they've come in, they have no sensation, they have no muscle strength, and they may even have gangrene, and this is immediate amputation for those. Okay, question 14. A 59-year-old man presents with acute left leg pain for 3 days, worse with exertion. Today, the pain is now severe at rest, and his foot is cool and going numb. But he's got cardiovascular risk factors. There's his meds. His vital signs are normal. His left foot is pale cool with reduced sensation and no pulses, but muscle strength is normal.